Well, hey guys, we're live. It's Tuesday afternoon, about 4:45, and I got finished with all my surgery today, and nobody's in labor, nothing else to do right now, so I figured I'd jump online, see what questions you guys might have today. So, just refreshing my stream here to make sure everything's working okay. Looks like it is. So, hey, welcome. I had a couple things to talk about, but we'll see if anybody's joining. Hey, welcome everybody. Tuesday afternoon, just doing a quick live chat, see if anybody has questions. I had a couple things that we could talk about if people don't have anything to say right away. So maybe I'll just get started with that. It's a really common question that I get almost every day. Almost every day, somebody talks to me in the office about complaints about decreased libido. And there's several aspects to decreased libido that are worth thinking about. The biggest one is what we call a dysfunction in desire. So just the desire to have intercourse with your partner. And there are a lot of reasons why that might be. A big one that you always want to ask about, I always ask about right up front, is if there is any pain. Hey, Dee Dee, how's it going? Thanks for jumping in. So just talking about decreased libido for a minute. I got other things to talk about too. But just to kind of get the conversation going, this is a pretty common question. The first thing that I always think about is if there is pain, because of course, if there's a source of pain, then, a lot of people are probably not interested in having sex in that situation. So no surprise. So a good physical exam to see what might be going on there. A really common time when that can happen is postpartum. So you had the baby and you're nursing. And when you're nursing, it turns out that you don't make very much estrogen, and thinning of the vaginal tissue can cause it to be tender, and that can cause pain. So that's a pretty common one. Also, if there's any concern about how things have healed after delivery. So, doing a good exam, making sure everything's healed up good, and then sometimes considering using some estrogen cream to help kind of get things back in order. It does seem to help. So that's the first thing. The other big part of it for women that's different than men for the most part is just kind of the emotional side of it. And I say that not to say women are emotional. It's more to say that men are unemotional. and so, I talk to people about it like, it's very complicated in terms of how you feel about the situation, the relationship status, how things are going there. That's one of the biggest predictors of sexual satisfaction is satisfaction with the relationship. So, to the extent that if there are things that are bothersome in the relationship that are kind of under your skin, that's going to affect, sexual interest. So it's understandable, and that's different than guys. Guys are pretty much just on or off, not a problem. So I always talk to people about, to the extent that you can address any issues there, it's going to help. And then, the other one is there are some medical things that are related. And one of the biggest ones is actually medication-induced reduced libido. And so things like SSRIs, Paxil and Prozac and Celexa and Lexapro, things like that can definitely have an impact on sexual desire. So can certain blood pressure medications. So it's always good to review your list of meds with your doctor and see if any of those might have an effect. Now, the other big topic that people always ask is, there must be something wrong with my hormones. Can you just check my hormones and see what's going on there and maybe fix something with my hormones? It makes sense sort of intrinsically just to go, well, if something's low, make it normal and everything's good. The interesting thing is that the data really doesn't back that up, and there's some examples that kind of explain that. So if you look at people who have high levels of testosterone just naturally for one reason or another, and the best example would be in people who have PCOS. So patients who have PCOS tend to have higher levels of circulating testosterone than people that don't have PCOS. And interestingly, there's no evidence that they have increased libido. So it's kind of the opposite. So that in a situation where there's, excessive testosterone, it doesn't really seem to make them more interested in sex. And there's no proof that even when administering testosterone to patients that it really increases their libido, maybe with the exception of one study that I remember reading about it was really in young women who'd been surgically induced menopause, so they had their ovaries removed. So they're not making any testosterone. They still make some adrenal testosterone-like hormones, but it's not exactly the same. In that situation, there was a small study that looked at testosterone gel, and it did improve things a little bit. So, in the surgically menopausal woman, there might be some benefit to consider using testosterone gel, but in the average person who still has ovaries, it's not been proven to be effective, and it's even been studied at what we call supraphysiologic levels, so higher than what you would normally have in your body. And there's just no good proof, unfortunately, that it makes a difference. So it really comes back to the first two, addressing any pain issues, and then trying to address any of the psychological aspects of things that could have an effect. So that's kind of a quick little summary. I got a question popping up here from Rachel. Hey, Rachel, how's it going? Thanks for your question. Let's see. She says she's 46, want a third baby, very scared of miscarriage or ectopic, had an abruption with her first son 21 years ago. Would a third be safe? Well, in and of itself, I don't see a problem. Whoops, sorry if I bumped the microphone, if anybody just blasted your ears. The main concern is not so much the prior history of an abruption, although the question still is, do you know what the reason for the abruption was? Did you have preeclampsia? If you had preeclampsia, that's a risk that it could happen again, certainly. But just an abruption in and of itself doesn't really put you in any particular higher risk. So my only other big concern is just age-related. There's just a pretty high rate of miscarriage at that age, and that's one of the things you mentioned you were kind of worried about. It's pretty substantial risk of miscarriage, primarily related to chromosomal abnormalities. So off the top of my head, I can't quote you a number, but the rate of live-born babies with chromosomal abnormalities at 46 is probably in the 15 to 20% neighborhood, which is really high. I mean, if you look at someone who's in their 20s, it's less than 1 in 1,000. So it's substantially higher. But the key was I was quoting your rate for live-borns. So the miscarriage rate is actually very, very high and primarily related to aneuploidy or abnormal chromosomes. And that at 46 is the big thing. So it's not to say you couldn't try, but there's definitely some risks there. One potential way to get around that particular risk, if you're willing and if it doesn't work out, using your own eggs and your own ovaries, is to do IVF with donor eggs. And I tell everybody, the uterus really doesn't age. It's really your eggs that age. And so plenty of people in their late 40s have had babies. A lot of people you see on TV have had babies. I think a lot of those people probably do an IVF with donor eggs. So, you work with a fertility center, you do in vitro, but you use a younger person's eggs. And it's not horribly expensive when you start talking about in vitro. It's not that much more to do donor egg IVF. And there's even options for like donor embryo IVF. So, I always talk about that idea of, being a mom is one thing, and you don't even have to have had a baby to be a mom, obviously. But you can be a mom, be a pregnant mom, have a baby. It doesn't necessarily have to be genetically yours to make that baby yours. So there's lots of options out there. So age alone I wouldn't worry about. The abruption thing I wouldn't necessarily worry about unless it was preeclampsia related. But even then I wouldn't call that a deal breaker. And I think there's ways to get around the concerns about miscarriage and abnormal chromosomes, stuff like that, through the donor egg IVF, if that's something you're interested in. No preeclampsia happened out of the blue. Yeah, well, it's, when you say missing on scan, basically it's almost impossible to see an abruption on an ultrasound. And the reason is that the density of blood, fresh blood, is basically the same density as a placenta. And ultrasound really depends on differences in density to change the echo characteristics of how those sound waves return from the little transducer. So blood and placenta pretty much look the same. It's pretty hard to see a fresh acute abruption. Sometimes if you get an organized clot, you can see it, but more times than not, you don't. I've been doing ultrasound for 20 years, and I don't know that I've ever actually definitely seen an abruption, particularly in third trimester. Now, second trimester, they're sometimes a little bit easier to see. So at any rate, I don't worry too much about that if you didn't have preeclampsia. Now, you said can a long time on Cerazette, which I actually don't know what Cerazette is, so I'm assuming maybe that's some kind of birth control pill. That particular name doesn't ring a bell. There's a million generic birth control pills, so I'm just going to look it up in my little handy-dandy drug reference here real quick and just see if that's what if I'm on the right path here. If I'm right, you can tell me while I'm looking this up. Fire away. Cerazette. You know, I don't even see that in my list of drug reference. I got nothing. So, a mini pill. Okay. So yeah, the mini pill is just progesterone, and birth control pills in general, never mind the mini pill, definitely applies for this as well. There's no evidence that the use of really any hormonal birth control is associated with infertility. So, and in fact, in some ways, it may even be the opposite. Now, this is not proven. This is just me thinking out loud. So, every month when you ovulate, you lose an egg. Sometimes you lose a couple of eggs. And so, when you go through life, it's kind of like, well, however many eggs you have left is how many eggs you have left. And that's kind of part of your fertility is egg quantity. And then, of course, the other part is egg quality. So, age is the quantity thing. But if you've suppressed ovulation for many, many years, then I would expect that you may have a little better than average for your age in terms of egg quantity. The quality thing is really nothing you can control. That's just kind of age and genetics and luck and all that. So actually, if anything, it might be helpful that you were on birth control pills for a long time. That's not proven. That's just kind of me thinking out loud, but there's definitely no proof that it reduces your fertility. So hopefully that's helpful. Those are all really good questions. Thanks, Rachel. Let's see, just peeking at my stream over here to kind of see how things are looking. Looks like everything's working okay. If you guys can hear me and see me okay, let me know. I changed up this microphone. Some of you may have already heard me on one of my tests a couple days ago. Hoping that this sounds better than streams that have happened, in weeks in the past. Hey, Tori, let's see. So to some extent, this is covered in a lot of detail in one of the videos on the channel that's called Evaluation of Recurrent Miscarriage. It's always obviously really encouraging when you have live births in the past. Oh, thanks, Dee Dee, for the sounds better. I'm just looking back. So, 2 living kids, it makes you feel a heck of a lot better about the situation in the big picture. I know it doesn't make you feel any better in the current moment. But what it says to me is it proves you can do it. So it rules out certain basically unfixable genetic problems. So if you have somebody that's had 3 miscarriages and never had a live birth, I worry actually, a fair amount about there's possibly some kind of underlying chromosomal abnormality and they're never going to have a live birth. But when you've got live birth sitting there, it's like, well, proves that. So it's not that. We typically test for antiphospholipid antibody syndrome, which is a blood test. It's kind of an autoimmune disorder, and it is treatable if you detect it on blood work. It's fairly rare. I've seen a couple over the years with patients who had recurrent miscarriage. You can develop that over time. So if in the past maybe you didn't have it or it hadn't developed yet and you had healthy kids and now not so much, it could be from that. So definitely checking for antiphospholipid antibody syndrome with some blood work is a good idea. Checking out the uterine cavity with either hysterosalpingogram or saline infusion ultrasound tells us a lot about the health of the uterus. And sometimes you'll find a uterine septum or something, but typically, not if you've had a couple of live births. So it can boil down to just bad luck. If you've checked all those things, it's not wrong to check the chromosomes of either the parents or of, say, one of the miscarriages with the tissue. We can do that type of testing. But typically when you have healthy kids out there, what you're going to find is, yeah, right. So thanks, Tori. I can't say those things out loud because of privacy, but you can say whatever you want. So exactly. So, we'll look inside the cavity and see what we see. Just trying to stick to the federal privacy laws there. So, take a look at the cavity, make sure it's good. It'll probably be fine, but we'll look and make sure. And then kind of go from there. But it's not wrong to think about testing the chromosomes of a products of conception, mostly because it's going to tell you, like, well, what was it? And 9 times out of 10, it's going to be, oh, that's one of those kind of random, it's going to be a trisomy or a tetrasomy or something weird. But most of those are, they're just sporadic and random. And so, yeah, it's all good. Probably at the end of the day, what I'm going to tell you is if everything looks good, keep trying and you'll have a baby. It's hard when you're in the middle of it. But again, it's way encouraging when you've had kids in the past. So we'll definitely check everything out, but chances are good that things are going to be fine. So good question. Thank you. And, let's see, you guys have any other questions off the bat? Cause I got all kinds of things I can just ramble on about. Just going to take a drink break here. Oh, you're welcome. Okay. So let's see. If anybody else has questions, jump in. I'm just going to kind of look back through my notes. I always have like little stash of topics to talk about. So here we go. Let's see. We talked about the decreased libido. Let me look back through my notes on decreased libido and see if there's anything else. Oh, another interesting thing I didn't mention in the discussion on decreased libido is, if there are, oh, good, thank you. What I think of red raspberry leaf tea and evening. Oh, okay, so what I think about red raspberry and evening primrose oil, I don't think they're harmful. That's for sure. I'm not aware of any data that says they're of any particular benefit. So, there's no studies out there that show that they're going to help you go into labor or do anything good for the pregnancy or make things happen sooner or make your cervix dilate or anything like that. I don't think they're causing any harm. So I don't worry if someone says they're using that stuff, but, I'm just not aware of any data that's going to help. Oh, anyway, I was talking about this decreased libido thing for a second. One more thing that I forgot to mention, anybody who has any kind of like pelvic floor dysfunction, so urinary incontinence, that can be associated with decreased libido also for obvious reasons. I think I pretty much covered everything on my decreased libido talk that I wanted to tell you. Let's see if I got any other things ready to talk about here. Well, this is one, I haven't talked about it at all. So anybody jump in with questions if you want. But one thing that comes up for every pregnancy around 28 weeks is to talk about, well, what's your blood type and what does that even mean? So let's see. Megan, thanks for the VBAC. Have appointment. Oh, good. Well, hopefully things go well. Definitely I would walk in there, Marina killed your libido. It's interesting. We'll talk about Megan's thing for a second, but the VBAC question, I always encourage folks, look at the little link at the bottom of that video where you can calculate your own chances of success. And then you kind of walk in knowing what that number is. And like I've said in the video and I've said in other places, if the maternal fetal medicine units network's model predicts a 60% chance of success or better, then I encourage people. I mean, even if they're thinking they want a repeat C-section, I'm going to say to them, hey, just so you know, this is what the model's predicting, which is really encouraging, and maybe you ought to consider giving it a try. So, if you calculate the numbers and you see 60 or better, then you should walk in there feeling confident that you're in a good position. And like I said, that's backed up by the American College of OBGYN. So I always find it kind of hard to argue with that, considering they're like the people who basically manage all of our educational stuff, going through residency and do a lot of the board certifications and things like that. There's definitely still places that are not supportive. Dee and I have talked about that back and forth a lot. It's more of a regional problem. It has to do with availability of doctors who will even do it, which is a shame when there's places that won't. I think that it could avoid a lot of C-sections for a lot of people and do a lot of good. So yeah, good luck indeed. I agree. And then Dee Dee said, Morena killed my libido. It's interesting. I talk about this a lot, but it's a very, very low dose, and it doesn't mean that it doesn't have effect on your body. But it's just interesting that such a low dose of progesterone can affect people, and some people are probably just sensitive. So, oh wow, Megan got 79% chance. That's fantastic. I mean, good luck. Fingers crossed. Let's see, only one hospital in the area. Yeah, if it's close, I would give it a go. Tori was asking if SSRIs kill libido. They can, and I was talking about that a little while ago. There's pretty good evidence that SSRIs can affect sexual response in a couple different ways, one of which can be desire. Now, it's a little tricky because depression can affect libido, and so it's always, to me, kind of hard to unwind which one is it. Is it the depression talking, or is it a side effect of the medication? So it's tricky to know with certainty, but I think there's some potential there. Sometimes I have a patient on SSRIs and they're complaining about that as a side effect. I'll add in Wellbutrin because the dopamine from Wellbutrin is thought to sort of counteract some of the effects of the SSRIs with regard to libido. Yeah. So I'm just curious, Dee Dee, when you had the Mirena taken out, did things get better? Fingers crossed. Let's see. Uterine rupture, can your scar tear open after several C-sections? Yeah. The number one risk risk of a C-section is uterine rupture, and we quote that risk as about 1% after one C-section. And we think that probably in general, 2 C-sections, it doubles the risk. So you're sitting at about a 2% risk. But I don't necessarily think you're talking about a uterine rupture. Oh, good. Sorry, I'm having like 3 conversations at once. So anyway, if a uterine rupture happens, it's a big deal. But the big thing to put in perspective is it's rare. It's really rare. And the flip side is that the risk of repetitive C-sections is also high. And, when you start talking about 3-4 C-sections, I just put a video up a couple weeks ago. But you start getting into some substantial risks as well, bleeding being one of them, bowel obstructions, injuries to bladders. And then the big one is the placenta accreta business, which is where, if your placenta implants over that C-section scar, so typically over the cervix, then that's called placenta previa. And, if you're talking about you've had a couple C-sections and now you have a placenta previa, the risk is possibly as high as 30 or 40% of a placenta accreta. And that's life-threateningly bad for mom and baby. And the risk only goes up from there. So if you say you had 3 versus 4 versus 5, at 4 C-sections, the risk of an accreta, if you have a previa, is up at 70%. So, a big conversation I have with people in the office, if they've had 1 or 2 C-sections, is about the VBAC, trying to avoid going for a 3rd, 4th, 5th C-section. If that's where you think you're going with your family, then you really are statistically much better off trying for the VBAC, because the risk of accreta can be life-threatening. And, ask any OBGYN who's done one, it's probably the scariest thing that's ever happened to them. Uterine rupture's up there, but it's not, to me, as scary in the sense that, if uterus ruptures, you know it right away. You go in and you do a quick C-section. If everybody's ready, which is how it's supposed to be, you should have immediately available OR, immediately available anesthesia, and immediately available doctor to get things rolling. If you can get that baby out within a minute or 2, probably the baby's going to be fine. There's some risk of bleeding and injury for the mom, just because it's such an emergency rush type C-section, but not likely to be as bad as what an accreta can be. So it's like I tell everybody, once you're in that situation, you've had a couple C-sections, you're pregnant, there's no risk-free venture at that point. So it's all about trying to mitigate the risk, trying to pick the option that sounds the best to you, trying to pick the option that offers you the lowest risk overall. So Dee Dee was asking, can you find an accreta? Not always, but it's really all about placental location. So if the placenta's over the cervix, so placenta previa, that's where the risk is. If the placenta is not over the cervix, the risk is about 1%. We really don't worry about it because it's really thought to be associated with the proximity to that uterine scar. So if you're nowhere near the scar, then it just doesn't make sense that it would be a problem. So first things first is, where's the placenta? Once you know you have a previa and you've had prior C-sections, low, not previa, yeah, previa really. Low lying, you still look at it, but it's really placenta previa. That's the one you got to really be concerned about. Once you're in that category and you're looking at it, I would always refer those folks out to the perinatologist, let them do their own scan. I try to look at it. I usually can pretty well tell, but I like a second set of eyes on those. There's sort of an interface between the placenta and the uterus that's normally fairly distinct. You can usually see it, but in an accreta, that distinction becomes fuzzy, at least in places. It may not be the whole thing, but you may be able to find a nice boundary. You're kind of following it down, 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 and then all of a sudden, poof, there's not a boundary there anymore. That's an accreta. Sometimes there's some vascular changes you can put on the color flow and see things that light up, and that can be kind of concerning. So ultrasound will pick up a lot of them, but again, it comes back to really that high index of suspicion. So the history of number of C-sections, where's the placenta, that's what's really going to tell you. Okay, let's see, Aaron. Hey, Aaron, curious about working while nitrous is being administered as dental hygienist. Well, you answered my question. I was about to ask you is, do you have a scrubber, evacuation basically. So I have patients who are anesthesiologists, nurse anesthetists, who put people to sleep with general anesthesia all day long. Nitrous is basically harmless. So I wouldn't worry about a little leaking of nitrous, especially with the scrubber in place. I have people who are given, halogenated general anesthetics all day long. And even in those situations, same thing. They have capture systems, they have scrubbers. That's all set up for the people's safety who are administering the anesthesia. So I don't think there's really any concern. And in fact, nowadays, nitrous is actually getting a little bit of traction as an option for anesthesia in labor for a patient to administer to themselves. So yeah, I don't think it's anything to really worry about. The other one, of course, with dental people and say X-ray technicians and whatnot is, the question about the X-rays, and it's kind of the same principle. Most OSHA, they have systems in place to monitor radiation exposure. You're supposed to have lead shielding and a certain distance away from the patient and all those kind of things. And all those systems are in place to minimize the risk of exposure to radiation for people who work in healthcare. So kind of same answer. I have a lot of patients who are radiation techs or X-ray techs. So I tell them the same kind of stuff. So good question though. Hey, just curious while you guys are out there on the stream, as we get going, my computer starts to heat up and the fan starts blowing. I'm wondering if you can hear that fan. I've got my laptop a little bit away from the microphone, and I'm just wondering if you can hear that whine from the fan. So yeah, other questions. I forget, somebody asked a question that was good. That kind of got me onto other topics, but look back at my notes and see what I was going to tell you about. Oh, there's this whole the blood type business, so the RH factor. So if anybody has questions, jump in. I'll answer them in a minute. But for a minute, I'll just tell you a little bit about this RH factor business. So every pregnancy we want to check the mom's blood type, and the reason is we're looking for this RH factor, and that is a protein that's on the surface of some people's red blood cells. Oh, I can barely hear the fan. Thanks. So if you're Rh positive, then that means positive means you have the antigen present, the protein present. And if you're Rh negative, then you don't. And so it's really an issue for people who are Rh negative. So A negative, O negative, stuff like that. In that situation, what that means is that your body does not recognize that protein. It doesn't know it exists until it gets introduced into your body, potentially by a baby. So there is some mixture of blood from the placenta, from the baby's side to the mom's side, and that's how the potential exposure occurs. Now, it can happen from bleeding in pregnancy. It can happen at delivery, and sometimes it happens without any outward symptoms. You just didn't even know. So if someone's Rh negative, we check their antibodies to make sure they haven't developed an antibody response along the way. And then at 28 weeks, we routinely give a dose of RhoGAM. And what RhoGAM is just these little antibodies that are against that Rh factor. And they bind up any sort of loose red blood cells that are floating around in the mom's circulation from the baby to basically fool your immune system not to worry about that protein, because it's all good. We got some RhoGAM and that took care of it. So that's the idea of the Rh factor. There are other factors that are out there. They're just not as common. So we do see them, relatively speaking, more frequently in pregnancies nowadays, because the RhoGAM thing, pretty much if you get RhoGAM, you're good. So other antigens have started to sort of statistically be more frequent. So there's different ones like the Lewis antigen, Kell antigen, those types of things. They're less common, but they're out there. About 10% of the population has them. So if you had a baby that was Kell positive or Lewis positive or Duffy positive, then there's this potential for antibody response against those red blood cells. And it's the same kind of problem now that your immune system is sort of on the attack. You can pick that up on an antibody screen, which is why we always do antibody screens in early pregnancy. They're not as treatable as the D antigen or the Rh factor. There's no RhoGAM, say, for a Duffy or a Kell or E. So basically, we just watch those to make sure that those antibody levels don't go up. And if they do, we start to monitor pretty frequently with some special ultrasound tests that can tell us if the baby's developing anemia in the uterus. So Dee Dee was saying, is there anything you can do to prevent jaundice in a baby? Well, that jaundice is mostly related to ABO incompatibility. So let's say, for example, your blood type's O positive, so we're not worried about the RhoGAM thing because you're not negative, but your blood type is O. If dad's blood type is A or B, then your body hasn't seen that type A or type B of blood before, and it's kind of the same thing all over again. They don't tend to go much on the attack during pregnancy, but you can see some increased turnover of red blood cells at delivery. And so that's a potential cause for jaundice, is ABO incompatibility. Not much you can do about that because it's related just to the blood type of mom and dad. Having the bilirubin levels checked and following closely is how you follow those. Making sure the baby's eating and pooping and peeing is how they get it out. So being sure that that's being monitored is the big thing. But so far, no good treatment for ABO incompatibility as it relates to jaundice. The other thing I tell people, we do, delayed cord clamping has become, pretty commonplace and I think more or less the standard of care at delivery. But if you have a known history of jaundice, that might not be the best idea because basically you're just putting more red blood cells into the baby's circulation at delivery, and that may increase the risk of jaundice. There are some studies that show slight increased risk of jaundice, but they didn't break it down if they were ABO incompatible or not. So, but if you had a history, I would probably not do delayed cord clamping. So that's probably the only other thing from a prevention standpoint that might reduce the risk. Rachel, do you have an opinion about ovulation of boys before and after girls? Oh, so yeah, kind of gender selection with regard to timing of conception or intercourse and all that. The gist of that is it's a complete myth. So I forget the guy's name who what the heck was his name? I made a video about it. It's in my list way back there somewhere. It's actually pretty funny. So if you want to watch it, it's called How to Get Pregnant with a Girl or something. It's pretty hilarious. I think I was very amused. But basically there's just there was this one doctor in the 60s who made this observation that, X-bearing chromosomes from sperm versus Y-bearing chromosomes sperm are shaped a little different and swim a little different in terms of how fast they are or whatever it was. Supposedly one's faster than the other and live longer or not. And so that was kind of the theory, is like, if you could make them, go in there sooner, they live longer, swim faster or whatever it was. There, although there was some laboratory observations with semen analysis from the dude that published, yeah, there it is, the Shuttles. Yeah, thanks, Dr. Shuttles. He had some lab stuff in the 60s. There's just no proof from the clinical side that it is effective. So there's always somebody who said I did it and I got it. Well, you had a 50-50, good job. I'm happy for you, but I really don't think it was that gender selection. So about the only thing you can do that's not super duper high tech, I mean, this is kind of like medium dose high tech, is called cell sorting. So it is true that X-bearing chromosome sperm are different size than Y-bearing chromosome sperm. And you can sort those by what's called flow cytometry. It's expensive. And only a few places in the country do it. There's a group in California that does it. There's a group on the East Coast. I forget what town. But you have to go there. They do the procedure. You have to have an insemination. And it's not 100%. I think, it'll bump you up in that 85, 90 neighborhood, but definitely not 100. So, and it's not cheap. It's probably a few $1,000s to do one try. And there's no promise you're going to get pregnant off one try. So pretty expensive, but some science behind that at least. And then the other one that's really high tech is, in vitro with pre-implantation genetics. Now you're talking 15 grand or more. And most in vitro centers won't do it just to get a boy or a girl. But let's say, I'm making up a scenario, but let's say you got 4 girls and no boys and you just wanted one boy. Then that concept's called family balancing. And so some centers will do it for family balancing. Now, another medical indication is, and I've actually seen this, a person who was a carrier for hemophilia. So if she had a boy, the boy was going to be affected with hemophilia. And if she had a girl, it wasn't. And so they actually did select a girl, just to not have another kid born with hemophilia. So, in that situation, there's a medical reason. And so I think in those situations, the IVF people are a little bit more into it. So, yeah, good questions all around. But yeah, Rachel, check out that video. Let me know. Put a comment on it if you watch it. Let me know what you thought. It was super fun to make. There's a couple in there like that are kind of these Mythbuster type videos. So check it out. Let me know what you think. It's a good question, though. Let's see. I'm going to read, Megan, your comment. I'm going to take a little sip of water. So I'm going to back up here so I don't blow your guys' earballs out. Let's see. So Megan says, son was born. He had oxygen, ended up in the NICU for a couple of days. On oxygen for what's called a pneumothorax or popped lung. Do you think that's something to worry about? No, it's a result of primarily increased difficulty breathing. The baby's working harder to breathe. They're giving supplemental oxygen. Sometimes you didn't say, but through a ventilator tube. And it just produces a little bit higher pressures in the lung, and so there's a little bit of higher risk for a pneumothorax in babies who have respiratory distress. So it's not so much the oxygen and all that, but it's more about the fact that the baby had some degree of respiratory distress. So the question really is, what was that about? Prematurity is a risk factor, of course. And so what can be done to reduce risks of prematurity should be done. Not delivering a baby intentionally early unless there's a valid medical indication is also obviously very important. So I think if you do those things, then you're doing all the right stuff. But bottom line is just because it happened before, I wouldn't worry that's going to happen again. Let's see. What percent of babies do we deliver that are overall healthy? The vast majority. Let's see. Had a C-section, 39 and 2. Yeah, that's just a fluke, Megan. That's just a fluky thing. I wouldn't worry about it. It's probably never going to happen again. So, yeah, I mean, you did the right thing in terms of, timing of delivery. C-section is a slight risk factor for respiratory distress, which when you think about it, there's some logical reasons why that might be. So, think about a baby in the womb. They're underwater. They're in the bag of water. They're getting their oxygen through the placenta via the umbilical cord. And then, the minute they're born, the cord is clamped and now you got to breathe. And you just came out from underwater in the pool. So in a C-section, you just pulled out and okay, breathe. And, that can cause some higher, like I was saying before, stress with breathing, and that may have been somehow related back to that pneumothorax you were mentioning. compare that to vaginal delivery. So let's say now you're back underwater, but this time you're not coming out through a hole in your belly, you're coming out the right way. There's a definite squeeze. Yeah, big baby, so it's a good reason for C-section. But anyway, if you can get them out vaginally, then as they come through the birth canal, it's like that the lungs get squeezed. So think of the lungs like a sponge, and then as you're coming out vaginally, you get a nice squeeze. It kind of wrings out the water, and it reduces some of that fluid in the lungs. It improves ventilation, reduces the forces necessary to ventilate the lungs, and probably reduces the risk of things like pneumothorax. So big baby, maybe have a smaller baby, as if that's really much within your control. But if you could, that's helpful. About the only thing you can do as far as birth weight is, relates to weight gain in pregnancy. So the more weight you gain, the higher the risk of difficult deliveries and C-sections and stuff like that. So there's actually a video in my list. I think it's on the playlist titled Labor, Delivery, and Postpartum, that talks about how to reduce your risk of C-section, and that's the big one. It's like, don't gain too much weight. There's a slide in that video that looks at the Institute of Medicine's guidelines for weight gain in pregnancy, and it's all based on your BMI, so how much you weigh for your height, and then it breaks it down as to how much weight you should gain for the pregnancy. So you might take a look at that. If you didn't gain excessive amounts of weight, then really did everything you're supposed to do. There's some evidence that aerobic activity in pregnancy also creates leaner babies, just like it creates leaner people. So, to the extent that you can be more active aerobically, it may burn a few calories that would have otherwise gone to the baby, and that might be helpful. So it's worth a shot. All right. So if anybody else has questions, jump in. Trying to see if I can scroll back up to see if I missed any questions while I'm seeing if anybody else pops anything up. There we go. Now we're scrolling. Let's see. I think I'm pretty much caught up. So I did gain too much weight. Oh, there it is. Back down to pre-baby. Yeah. So it's all about weight gain in terms of the modifiable risk factor. So yeah, try to keep it to a minimum. I always tell people 15 pounds. 15 pounds is kind of the minimum for the baby. And if you're at the appropriate weight for your height starting, and you only gain 15 pounds, then you've done everything you can. So yeah, good luck. Fingers crossed. Aaron, episiotomy versus tearing. There's a study done by a guy that I trained under in med school named John Thorpe. It was published 20 plus years ago. This issue is addressed. They did it's amazing. They did a randomized controlled trial of moms in labor, and they literally, I can't believe they got people to agree to this study. They literally randomized them, flip a coin. When the baby comes out, we're either cutting an episiotomy or we're not. And amazingly, they got the study done. But the interesting thing was, it really proved that if you assess the overall damage that is done after the baby's out, it's worse if you cut. And it makes sense. I mean, if you weaken the tissue and then you push a baby through there, I mean, it makes sense. You're going to probably cause more damage. Now, the argument's always been, yeah, but, I did this because I thought that the damage was going to be worse. And I mean, I get the logic, but the data's just not there. So, I'm the chief of obstetrics at my hospital. And so we look at things like episiotomy rates. And it's a goal at the hospital that I work at for everyone, for all providers, to have that rate under 5%. So 4% or better is a goal. And so I think, hopefully we'll see as time goes on that rate comes down. So Tori, what if you're smaller to begin with? Well, it's all about that BMI. So, 5'3", quote unquote, ideal body weight's 115. That's skinny, but that's what ideal body weight is. So 120, you're still in the green zone, normal weight. So 15 pounds is still a reasonable goal, like minimum for the baby. If you're underweight, then you need to gain more. Now, it's not to say that gaining more than 15 is wrong, but we were talking about, how can you try not to have a 9-pound baby next time, when I was talking about that a minute ago. So, if you're normal weight, then, and you haven't had a history of giant babies, then, 15 to 20, 25 pounds is fine. 25 to 30 is getting up there. More than 30 is too much. So, so 15 really is considered the minimum for the baby. Good question, so. All right. This is good, man. You guys are cooking. Anybody else have questions out there? Somebody new just jumped on. Welcome. I don't know if you know or not. Wes Davis. Hey. And I work over at Circle of Life in Ogden, and I have this YouTube channel, and you probably know that because that's why you're here. But you never know. Someone may have randomly found me. Who knows? And we're just talking, answering questions mostly about pregnancy and birth and stuff like that. Rachel had a question. Did I miss it? Oh, sorry. Yeah, thanks, Didi. Didi, I need to make you my moderator. You do a great job with this. Is hypothyroidism a risk in pregnancy? Yeah, interestingly, it's actually a risk factor for infertility as well, in terms of reducing your ability to get pregnant. Now, once you get pregnant, hypothyroidism is still an important thing. It is important that you're appropriately replaced with your thyroid medication. So we check thyroid levels, about every month or two throughout pregnancy to be sure that you're replaced appropriately. It takes pretty bad hypothyroidism to cause problems that are noticeable in a baby. So there's data from a long time ago that looked at like just grossly hypothyroid women who were untreated. And there's kind of a correlation between how bad your hypothyroidism is if it's not treated, and a reverse relationship with baby's IQ. So there's definitely some neurological development that thyroid obviously plays a role in. So it is important, but most people, when you're pregnant, you're getting monitored, you're not going to get to the kind of levels I'm talking about. But if you had somebody pregnant walking around with a TSH of 20, yeah, that's a problem. But if someone's, if our goal is to keep you on the low end, 1.5 or 2 for your TSH, and someone's walking around at a 4, I'm not really stressing about that. I'm going to try to help it get a little better, but I'm not freaking out. But if someone rolls in pregnant with a TSH of 20, I'm really concerned because that's not good. Good question. Thanks for pointing it out, Didi. Here's a random question for anybody that's watching, and probably, I bet you most of you guys are watching on mobile phones. If anybody is listening with headphones, let me know. I'm just curious. I'm getting more and more into the streaming thing. I'm looking at this other website called Twitch, where it's mostly gamers, but there's a lot of people on there doing these kind of just talking head type interactions with people. I had no idea. There's this whole sub-genre of streaming that is basically really quiet talking and really quiet sound effects. And it has a name. The name, I forget what they call it. It's some kind of abbreviation. But basically, they're taking little bean bags and crisping them in the microphone and whispering while they talk. And then they have the microphones set up so there's kind of a left and a right, and so they kind of talk over here into one ear, and then they talk over here into the other ear. It's amazing, and really weird at first. And I kind of was watching it. There it is, ASMR or ASMR or whatever. But after a minute, I was like, wow, this is kind of relaxing. It was kind of meditative and interesting, and then I kind of got sucked into it for a minute. So I kind of got sucked down the, thanks Tori, the ASMR hole, whatever that is. It stands for something, I forget what. But it was fascinating, and I thought I had heard of everything in my life, but obviously not. But I became acutely aware of, if you're listening with headphones, wow, you can hear everything. See you, Didi. Thanks for coming. Thanks for dropping by. Good luck. Hope everything's going good for you with the baby. So anyway, yeah, that ASMR or ASMR thing, it's pretty interesting. Well, let's see. We've been going for, 48 minutes. That's crazy. I'm just sitting here babbling. There's a couple people jumping on. I might watch it at night when I can't sleep. Yeah, there it is. Thank you. Autonomous sensory meridian response. I think it's like the goosebumps thing is what that means. Okay. Rachel, are twins more likely in older women have? Yeah, twins are. So age is a risk factor. And you're basically right. I mean, it's kind of nature, like make some more because hopefully some of them will work. So yeah, there's a higher risk and it's age related. And I just had somebody not long ago roll in pregnant with what they thought was going to be their third, and it turned out to be her third and her fourth, and she was older. So it is a thing. It's not a huge risk, but the general population, the risk is about what I think is 1 in 64 is the live born twin rate. A lot more are out there that just don't make it past the first trimester. So vanishing twins. I just had a vanishing triplet not too long ago. So she did have twins, but she started with triplets, which was pretty crazy. So yeah, and no fertility meds or anything, I don't think. So pretty nuts. It's a good question. And twins are a good topic. It's crazy, but in the last month, I think I've delivered 4 or 5 sets of twins. So I've talked about that a couple times on various live streams on here or over on Facebook. Sort of how do you handle twins? And I've talked mostly about at delivery. And if you guys have already heard this, just put up there, already heard it, stop talking. But how do you manage twins when it comes to delivery? And it really does all boil down to that first baby. Is the first baby head down? If the first baby's head down, we got options. You can try for vaginal delivery. I just had one within the last week that first baby was head down, second one was breech, had the first one head down, pulled the second one out breech, and it was all good. So that's definitely an option. If the first baby's not breech, unfortunately, it's a C-section. There's just no good way to turn the one baby that's coming out first. So that's one thing about twins. Another thing about twins is, how we manage them differently. It's mostly, in the first trimester, it's all about figuring out the placental situation. So we call that, are they sharing a placenta? Is that a monozyte? Is that a monochorionic pregnancy, one placenta, or do they have their own placentas? That's a dichorionic. And the dichorionics are less risk because they each have their own placenta. When they're monochorionic, there's a pretty high risk for this thing called twin-to-twin transfusion. So let's see. Sorry, I'm just going to text my son. He's down in Salt Lake, just finished. So let me tell him to get in. Cool, get in the Uber and come home. Sorry, guys. My wife's out of town, so I'm doing dad duty. Okay. So anyway, the deal about placentas is if you only have one, then there's a pretty high chance for there to be some vascular connections between one baby and the other across the placenta. And if they're balanced, then it's not so much an issue. Hang on, he's still, yes, I'm home. That's why I said come home. There we go. If the vessels across the placenta are balanced, so arteries going to arteries, veins going to veins, then it's less of a problem. But if you have arteries going to veins, then basically one baby kind of sets up like a pump and pumps blood from the arterial side to the venous side. One baby becomes a pump, and one baby becomes a recipient. And as a result, one baby gets too much blood, and the other baby doesn't have enough blood, and there's complications from that. Now, interestingly, when I first started residency, they were just starting this treatment where they would laser coagulate those vessels, and it was like a miracle. I mean, all of a sudden these babies were living because it's an extremely high risk if you get twin-twin transfusion, you don't treat it. So this is a new thing. So kind of this photocoagulation of vessels in twin-twin transfusion has really changed the game in monochorionic twins. So it's less of a thing than it used to be. Let's see, are they a risk to mother after several pregnancies? Twins, actually, my experience is if you've had a couple babies before, that's to your advantage. And the reasons why I think that might be are, well, number one, your uterus knows what to do. Your uterus is like, okay, cool. I've done this before. I don't need to freak out and try to have these babies early, although there's still some risk of that. It seems to me that's less of an issue when you've had kids before than when you have not. So in my own experience, I've seen less preterm births in moms who've had babies who then have twins versus moms who have not. So there's that. And the second one is kind of what I was talking about a minute ago, which is when it comes to delivering the second twin, and when it comes to delivering babies in general, it's always easier to deliver a second baby or a third baby. So if you've had a baby in the past and now we're having another baby now, it's easier because the first baby kind of paved the way. And if you've had a couple come through there, it's even easier. And now all of a sudden you're talking about, well, push that first one out and let's go get up there and get that second one. No problem. It seems to go better. Now I'll still try with a first time mom, and chances are it's going to go fine. I did it just a couple weeks ago. But it's easier when you've had kids. So yeah, I don't think there's any particular risks with regard to that kind of stuff when you've had kids before. I think it's overall good. The main risks with twins are, preeclampsia and gestational diabetes, and age is also a risk factor there. So it's maybe a little higher risk of seeing some things like that. I definitely watch for all those things in a pregnant mom with twins, regardless of age, but especially if they're older. I think that's a higher risk, but it's not a deal breaker. I've had plenty. Most of them do just fine. That's a good question. So, hey, Tori, if you're still on here, tell me, do you watch that ASRM or ASMR or whatever the heck it is? Do you watch that on Twitch or do you watch it on YouTube or where? Because I had never heard of it before, and I just stumbled upon it last night. It was kind of relaxing, though, I will say. YouTube, yeah. Everything's on YouTube. I hardly watch TV. It's ridiculous. I hardly watch TV anymore except for watching jazz games on regular TV. I'm so tempted to get rid of my cable subscription, but I need the internet. And the best internet around here comes from Comcast. Let's see. Stumbled upon it a few years ago by accident and thought it was super weird at first. Me too. I was like, what the heck is this lady doing? I mean, she was talking to this box that had ear-shaped holes, and she was coming over here and talking like that. And then she was coming over here and talking like that. And then she had little bean bags, and she was crinkling them up and making this weird noise. And then she was whispering. But after I kind of just closed my eyes for a second, I was like, wow, this is totally relaxing. So although it was weird at first, I agree, it's pretty cool. It might be a pretty good meditation kind of deal. I'm not a good meditator. I try sometimes. There's actually good, and there's good medical data out there to show that meditation is beneficial. It's good for your blood pressure. It's good for your cardiovascular stuff. My brain just doesn't really stop very well. I just always find something else to think about instead of whatever I'm supposed to be meditating. But this was distracting enough that it kind of helped. Well, cool, guys. I don't know if anybody has any other questions. Still a few people on here watching, obviously. Thank you to Tori and Rachel and Dee Dee and who else was on here earlier? Megan, for your questions, and Rachel. There's no answers if there's no questions, so I do appreciate your questions. Hey, I'm just curious from you guys. I'm assuming some of you maybe have your notifications on and you get a notification that I went live, if that's how you knew that I was on here, or did it just so happen that you were on cruising around and you noticed it? I'm just curious. Also, I'm trying to debate which platform I like better. I don't know. Some of you have maybe seen me over on Facebook Live versus YouTube Live. I kind of like the YouTube Live interface better, just from my side of what I can see and how it works. But the Facebook thing is there's just way more people on it. Our practice has a pretty big Facebook notification squad. Yeah. Thanks, guys. So anyway, I don't know if you know, but our Facebook is the practice Tori, and you guys know, but Circle of Life Women's Center. If you just search COLWC, you'll find the Facebook page. I think they have notifications on there too. I go live on there every week or two, but I feel kind of bad because it's the practice page, and I look back now and it's just my page. I'm just putting I don't mean to, but I just kind of keep putting stuff up there. It's oh, Dr. Davis is live. So I jumped over to YouTube to kind of give the Facebook thing a break. And I really appreciate you guys tuning in. Facebook, yeah, COLWC is the abbreviation. I think if you just do Facebook/COLWC, that's the practice one. My individual Facebook is Dr. Wesley Davis OB or something like that. Obviously it's a much smaller following there. But yeah, thanks for checking it out, guys. You'll see me there sometimes too. I try to kind of mix it up and not kind of keep hitting one platform over and over. I'd love to see this grow. I think I love the interaction. It's so much fun for me. I'm like done for the day. I have no pressure. I can just sit here and shoot the breeze, which is different than in the office when you've got patients waiting and somebody's in labor and you're trying to get to the next thing. So it's a much more relaxed format. It's really kind of open and flowy, and you guys can ask whatever you want, and I can kind of ramble on. So thank you once again for watching. I really appreciate it. I don't think I really have anything else smart to say right now. So other than just thanks for watching. I tend to do these, maybe you've already figured this out, but kind of Tuesdays or Fridays. This Friday I'll be in New York, so I doubt that I'll be doing anything. I do have a friend out there in New York that wants to do a live stream. She's kind of a fitness guru, so we might do something together. If you guys are interested in that, let me know. She's like a spin, yoga, meditation type instructor. She's friends with my wife, that has a pretty reasonable size online presence, and she's been working on some of this YouTube stuff and streaming stuff, and I've been kind of helping her out. So we talked about maybe doing like a little chit chat when I go out there. So if so, I'll at least put something up on the various social media outlets. So maybe you guys will know about it. But anyway, thanks everybody for watching. I think we'll call it good. I really appreciate your time and spending your time with me. So have a good one, and I'll see you next time. Bye.